My name is Dr. Kevin Ford, and I'm a member of Omega Psi Phi Fraternity Incorporated, and wanted to welcome you to Gamma Pi's Health Initiative monthly webinar. As everyone knows, this month is Heart Health Month, and today we have a special guest. We have Dr. Joseph Quash. Dr. Quash is a graduate of Howard University Medical School. He did his internal medicine residency at Georgetown Hospital and went to do his cardiology fellowship at Howard University Howard University Hospital. Dr. Quash is an interventional cardiologist, and so he did his interventional fellowship at the University of Arizona. So I'd like to bring on Dr. Quash.
Good morning, Kevin. How are you?
Doing great, sir. How you feeling today?
I'm thankful. I'm blessed to wake up this morning. I'm blessed to be a part of this fantastic event that you're hosting to help educate everyone about heart health.
Exactly. So when we talk about heart health, right? We're talking about cardiovascular disease, and it's a broad topic, cardiovascular diseases, right? We're talking about what's called coronary artery disease. We're talking about congestive heart failure. We're talking about arrhythmias. We're talking about valvular disease, peripheral vascular disease, strokes, all these different things. And so why is it important to talk about cardiovascular disease?
So thank you for that opening and question. What we know in the United States is that still the number one killer of African American men and women is coronary artery disease. And so to the extent that we can try to reduce that risk in the disease state that affects us so heavily, it's critically important. Now, I'm an interventional cardiologist, so I'm the person that you see in situations where you have a heart attack, vessels are blocked, I come in and open them up. But I am trying to be less busy. Okay, I want to put in place or give people the tools that allow them to try to reduce their risk of having these type of events and staying out of the emergency room. And so, in so doing, we talk about what are the risk factors or what are the things that can potentially cause you to develop coronary artery disease over time. Okay.
And so quick second.
Yeah.
So for people who aren't in medicine, when we say coronary artery disease, what are we talking about?
Great. So what we're talking about are blocked vessels. So you think of, when you look at the heart, there are a couple ways that we can think of it. You have the electricity and you have the plumbing. I'm a plumber, meaning that I am trying to break up that blockage in that vessel and reestablish flow through the blood pipes. You also have cardiologists that are electricians. Those are your electrophysiologists. They're the ones who primarily look at the heart rhythm and making sure that the electrical activity is occurring appropriately within the heart. So coronary artery disease is blocked vessels, obstructions to flow to the heart muscle that can ultimately lead to damage over time. So when we're talking about coronary artery disease, that's what we're talking about. We're talking about blockages to those vessels that supply the necessary nutrients to the heart muscle so that it works appropriately. So in terms of the things that we can do to reduce the risk of those obstructions, first and foremost is making sure that we can control blood pressure. Hypertension is the most common disease state that we see in people, that and obesity. But in terms of hypertension, we're talking about keeping up your blood pressure under very good control. Now, there was a time when good control we thought was less than 140/90. About 10 years ago, that number actually went down to less than 120/80. So if you're seeing your blood pressure is like 135, 138, and the bottom number is greater than 80, you're not at control. And so you need to let your doctor know that, because there are things that we can do to try to help get those numbers down. So it's critical that we keep good control of our blood pressure with a blood pressure goal of less than 120/80. The other thing that we talk about quite a bit is cholesterol. And so oftentimes when you see your primary care doctor, you're going to get some basic screening blood work, and amongst those are going to be things like cholesterol. So, ideally you want your cholesterol less than 200. We talk about good cholesterol and we talk about bad cholesterol. And more specifically, when we talk about HDL, which is the good, and your LDL, which is considered the bad. The HDL helps to remove that bad cholesterol so there's plaque, so that plaque doesn't build up. And when I say plaque, I'm talking about the thing that blocks those, that clogs up those vessels. The LDL, which is the bad cholesterol, is the one that promotes that clogging of those vessels over time. So we're really trying to keep that LDL number down and that HDL number up. And then ultimately that kind of obviously transitions into what are those things that can try to allow us to, keep those numbers down. Well, the big thing is what we eat and we take into our body. A friend of mine, I've heard people say, uh, I live to eat, or I eat to live, don't live to eat. Okay. So in so doing, recognizing that, we want to bring in those good nutrients, those vegetables, fresh fruits, those fish, chicken, not fried, skinless. Okay. But those are things that we want to think about in terms of better choices. The problem is that everywhere we go, in terms of whether we're walking down the street, driving down a car, we're going by places that do not promote those things and necessarily will help us in terms of eating the right type of food. And so you have to be cognizant that when you go out to these restaurants and these fast food places, you don't really have control in terms of what they're putting into that food. And so in that regard, you may be getting things that are very salty, things that not just hurt your blood pressure or have your pressure elevated, but also those things that may be high in cholesterol, fried fatty things, all things that are going to cause that bad cholesterol number to rise. And so we really want to be vigilant in terms of the type of things that we're putting into our body. So the things that raise your bad cholesterol are going to be fried fatty foods, and we want to stay away from those things. Now, so the other things that we have to consider in terms of risk factors, and a problem that continues to plague the U.S. And it has not gotten better with time, is the obesity epidemic. Okay, we have got to stop eating things that are going to cause us to gain weight, and because there's so many things that go along with being obese. Aside from coronary disease, it can affect your blood sugar. We're seeing more diabetes. So we really have to make sure that we're doing everything we can to try to, keep our weight down, because that ultimately can lead to these other things that I've been talking about. Another thing that we are doing better with as a country, but our population, maybe our population, African Americans, we gotta continue to cut out the smoking. I have seen that the numbers are getting better, but to the extent that that is something that we can easily modify by stopping ultimately, is something that we need to make sure that we are promoting, not just as physicians, but as friends and family, to those that may be smoking, because there's no benefit. It has a very clear risk for development of blockages into the vessel of the heart. But beyond that, it also has a significant risk in terms of increasing your risk of cancer. Mm-hmm. So there are a number of different risk factors that go along with trying to reduce, that can help us reduce the risk of blockages the vessels, and to the extent that we can educate, as we're doing in this forum, it's very important for us to do so.
And so, you mentioned, hypertension. And so I think everyone's heard it's the silent killer.
Yeah.
Right. Because most people don't realize they have hypertension unless you go in to get checked. And so my point, being the primary care internal medicine physician, is that you need to make sure that you're visiting your physician so that you'll know whether your pressure is elevated. Right. So you definitely want to make sure you don't want to not go to the doctors for 3-4 years and not get checked. And so that's so important to make sure you're going in so that because you can't feel that your blood pressure is high, usually, unless it's sky high, right? So we don't want to wait until that happens. We want to catch that early. So that's one of the things that I think. And also we talk about salt, salt with blood pressure. Salt elevates your blood pressure. And it's not only just shaking the salt, it's the hidden things that have salt. Dr. Quash has mentioned going out, fast food. We know that has a lot of salt a lot of times. Some of the condiments that we use, like hot sauce, a lot of salt, or we're just eating chips at lunch every day with all the salt, pretzels, peanuts that are salty. So it's the hidden salt that also is a big factor in elevating blood pressure. At least that's what I see in my practice when I talk to patients about blood pressure.
without question. And it's everywhere. And I'll just tell you a personal story of mine as well as to blood pressure. I it's interesting. Doctors make some of the worst patients there are. So sometimes just do as we say, not necessarily always as we do. And I say this for myself is that I was in a situation where I was in Mexico, and I was pretty good health. I would exercise on a regular basis, but I was feeling tired, and I couldn't understand why I kept feeling so tired. And we're going out to eat every night, what have you. And then I was getting some headaches from time to time, but I'm not thinking that could be me. And then I went to the office and I asked one of my assistants to take my blood pressure. My pressure was like 138/95. So I'm like, wait a minute, what's going on? So I say that to kind of reemphasize that it is important to get checked out and make sure go see your primary care doctor, get those numbers checked. My pressure had probably been up for some time, but I wasn't really tuned into it, and I didn't necessarily feel bad till it got even higher. So it's good to see your primary care. And also I'll tell people, if you're over the age of 40, it's not a bad idea just to get a blood pressure cuff at a CVS and have it at your home also, so that you can check in with it too. So, but I ultimately found out that my issue more so was that I wasn't sleeping very well, and I had so, too much salty food over that break. I adjusted my diet, drank more water, and fortunately my pressure goes down. And that's not going to be the case for everybody, but the key message is get checked out and let us help, address
like
it.
physical activity also, Doc, can you talk about the importance of that?
Critically important. I tell patients all the time, move it or lose it. Okay. From the standpoint that if you're not moving, you're losing something. You're losing years on your life. You're losing your mobility. You've got to exercise. And ideally, exercise that's meaningful. You want 30 minutes a day, 5 days per week at a moderately vigorous exercise. So you want to get your heart rate up. Whether you do, walking up hills, fast walk, jogging, running, what have you. You want to get that consistent exercise in because there are very clear benefits in terms of reducing your risk for heart disease. And even for those patients that may already have heart disease, you reduce your risk of reoccurrence. And you also, for patients that may have heart failure, it helps those with all disease states within cardiology in terms of improving long-term outcomes, engaging in regular exercise.
And I find that, most patients, you really have to be intentional about doing exercise because it's always something you're going to have to do. And a lot of my parents who have children, they're taking them to the different games and doing all these different things. They're just sitting in the car watching and waiting, right? That's your 30 minutes to an hour that you can get out and you can walk. You can do something during that 30 minutes. It's always nice to watch them, but take that time to also take care of yourself. I know we all have busy schedules, and so that's just a tip that I try to give patients to try to make sure that they take care of their exercise.
That's a beautiful point, and I think that part of it requires, and I talk with patients about this a lot. Part of it requires is our mindset on the activity has to change. We look at it at exercise as a leisure activity. We need to start looking at it as a life activity. Okay. And from the standpoint of this, there is no amount of money. Okay. Because people, I think we have this feeling like we got to work to make in terms of your quality of life, it is so much more important to have a healthy body that functions for you. Okay. Than to work yourself into the ground in a 9 to 5, what have you. So you have to prioritize it. We do have to work, to pay bills, what have you, but we also got to make sure that we are paying into ourselves, and particularly as it relates to our health, and that doing those things, making sure that you exercise, take that time, prioritizing that time as a life activity is critical because it will serve you so much longer down the road when you create these habits that can be with you for the rest of your life. So yeah, got to do it.
Right. And then you touched on also as far as obesity, weight loss, getting your your weight down. And then we have something more central obesity, your metabolic syndrome. Can you touch on that at all?
Yeah, metabolic syndrome is when you starts basically messing with not just your waistline but also your blood sugar and your cholesterol. You have this metabolic syndrome, and the problem with that is that it is also a significant risk factor for the development of coronary artery disease and peripheral vascular disease. So coronary artery disease, I mentioned, is blockages as it relates to the arteries in the heart. Peripheral vascular disease, we're now talking about clogging the vessels that may supply blood to your extremities. And so if you have family members that maybe have had to get amputations or have terrible ulcers that don't heal, those are all a byproduct of blockages to the flow of blood to your extremities. So yeah, that what goes along with obesity is often it's metabolic syndrome, which can result in significant disease as it relates to blockages to the heart, blockages to the peripheral vascular disease, strokes, all of those things. So that's why we got to make sure we modify that, get that weight down, get that exercise in, adjust that diet. I tell people as it relates to weight loss that it's really a 70-30 proposition, because I think people's mind typically says, well, I just need to exercise more. It's actually 70% of it really is your diet. So to the extent that you modify your diet, you need to do both are important and both are necessary to get meaningful weight loss. But to the extent that we can modify our diet, we got to put that at the forefront to help get that weight down. And then the exercise will also help in that process as well.
So, Doc, we know patients have different risk factors, and I think there are different ways we can calculate someone's risk of having heart disease. Can you talk about that a little bit?
Absolutely. So I want I want everyone out there to remember these 4 letters. Sorry, 5 letters. ASCVD. Okay, there's an ASCVD score, an atherosclerotic cardiovascular disease score. And what it does is it takes into account things like your age, whether you have race, whether you have hypertension, whether your hypertension is treated or not, blood pressure, smoking history. And what it does is it calculates a score. Okay. And what that score is your risk of cardiovascular events within the next 10 years. Okay. When we put those numbers in to get that ASCVD score, it gives a sense of what your risk is going to be. And based on that, we can make some decisions in terms of how aggressively we may treat your cholesterol. It helps us make some decisions as to whether or not we need to do any type of other further screening cardiovascular tests. And so it's vitally important. And also helps us make decisions in terms of how aggressively we address your blood pressure. So that score in and of itself kind of takes you down several different paths of intervention. And so it is important to ask your doctor what your ASCVD score is.
Okay. You just mentioned screening, right? And are there and we say screening is not when you're having any symptoms, any problems, right? So this is just screening is for people who don't have any symptoms of chest pain, dizziness, shortness of breath, or anything like that. But this is just a routine screening. And I think there are a couple of different tests for cardiovascular diseases that are screening tests. And can you mention those?
Absolutely. So one of the big tests that's out there that a lot of that we like to use is what's called coronary artery calcium scoring. And basically what that is it's a CT scan of the heart that is taking images to see if there's any calcium buildup on the coronary arteries. Based on that score, or it's called an Agatston score, it gives us some sense of what your risk is. In addition, it helps guide us in terms of making decisions about any further testing that may be required to assess if there's any significant blockages in those vessels. Now, in terms of decisions about who gets it, it's not a situation where everyone should just go and, I need a calcium score. That's not the case. It is a situation where if you've got significant family history of coronary artery disease or premature coronary artery disease, you certainly want to get that done. If you have a significantly elevated ASCVD score, that would also might be a reason why you get a coronary calcium score. If you if you're a smoker, that's also a group that we think about. Patients that have metabolic syndrome are also patients who we would recommend getting scoring. So the score again helps us assess your risk and then helps us make some decisions about what we need to do in the future. So if you have a score that's greater than 100, greater than 100 up to 400, we do recommend that you get some type of stress testing or assessment as to whether or not that calcium is causing obstruction of blood flow. When you start to get above 400 and 4 and 500s, then you start talking about potentially doing a more invasive study, which is a cardiac catheterization. That's the procedure that I do, in which you go into the vessels. We take a small catheter up to the heart muscle and inject contrast to see clearly if there's any blockages that might be related to that calcium buildup. So just because you may have some calcium doesn't necessarily mean definitively that calcium is obstructing flow, but depending upon the level of calcium that is visualized in that coronary calcium scoring dictates whether the type of study that we need to do to assess or not assess, depending if it's less than 100. As to what's actually going on in those vessels.
So if I could you're saying anyone with a calcium score probably over 400, you would really consider whether they need to go and get a more invasive test like a cardiac catheterization.
That's absolutely correct. Less than 100 to 400, that's kind of that moderate risk score. That's where we would put you on a treadmill, potentially take some pictures, or what's called a stress perfusion study. Under 100, we just want risk factor modification more than anything else. And risk factor modification, exercise, reducing your cholesterol, reducing your high blood pressure, so on and so forth.
Okay. Now, there's also something, well, actually, let's keep talking about other particular tests. Like even for peripheral vascular disease, there's a screening test that we use. Can you talk about that?
Absolutely. That's what's called the ABI, or ankle brachial index. And what we're doing there is we're checking the pressure in your upper extremity, compared to the pressure in your lower extremity. Now, in patients that don't have any type of blockages to those vessels in the extremities, those numbers should be very similar, pretty close. But if we're seeing a situation where there is a significant difference, i.e. there is a reduction in blood pressure to the lower extremity, then we get concerned that there may be obstructions to flow or peripheral vascular disease. So that ABI can be very helpful in giving us clues as to whether or not there's disease. And so then if that ABI is abnormal, then we will look into what's called arterial duplex study, which is basically an ultrasound of the leg, looking at those vessels to see if there is in fact any obstruction of blood flow. The reason why this is important is because we know that patients that have blockages or peripheral vascular disease are at 33% higher risk of also having coronary artery disease, which is not surprising because they're all a part of the circulatory system. There's no reason to expect that if you've got significant peripheral vascular disease or blockages in the legs, that can't affect the vessels that supply blood to the heart muscle. So if we see a situation where we have somebody who's got established peripheral vascular disease, then we have to take further testing in terms of assessing whether or not that might also involve the coronary artery disease. Here again is this a situation where some might suggest getting a coronary calcium scoring. Talking to potentially a cardiologist to make sure that there's nothing else that may be going on in that situation, given their significantly elevated risk of having that disease.
Right. And those that we usually screen with ABI tests, I think, are like diabetics who are higher risk of having blockage in their arteries. I think smokers, as we mentioned, it's the risk group. I think that we usually will try to get those ABI tests.
Absolutely. And even just one other test, particularly in our smokers over the age of 65, because we know that smoking affects the vessels dramatically. We look at what's called an abdominal ultrasound, just to make sure that there's no evidence of any type of enlargement in the aorta that can be related to that patient smoking.
Right, right, right. That's a very important point. Going back again, we also talked going back to the risk factors in cholesterol. There are you talked about the LDL, you talked about total cholesterol, HDL, but there's other cholesterol factors that we're looking at nowadays called lipoprotein A. Can you expand on that for us?
Yeah, that lipoprotein A is a very hot topic, particularly in the cardiovascular space, because now we're starting to talk about it as it is an independent risk factor, meaning that LP little a is along with elevated cholesterol, elevated LDL, smoking. We now start starting to talk about LP little a as being an independent risk factor for the development of coronary artery disease, and particularly amongst those patients that may have premature coronary artery disease that runs in the family. That's one of the things that we want to look at. So if we have somebody that comes in and say, Dr. Ford is seeing them and he says that they have an elevated LP little a, that also is an indication or a reason to undergo screening or CAC screening, coronary artery calcium scoring in that situation. Another one is another marker that we look at is called C-reactive protein. That also is an indication to undergo coronary artery calcium screening. So the point is LP little a in and of itself is something that is actively being studied, so much so that we are currently running multiple clinical trials looking at medications that specifically are targeted to reduce LP little a because it is an independent risk factor. It's not talked about as much, but it is something that you will hear more and more as the years go on, and you're going to start hearing more so about therapies related to LP little a.
Right. And this is just a quick curbside consult. Had a patient who maybe 30 had very high cholesterol. Then I got a LP little a test, and so it shows that they have it, LP little a. Right now, at what point would you get? You mentioned cardiac calcium scoring. I think they're a little young for probably right now. You want to just try to treat their cholesterol, diet, and so forth.
Yeah, particularly so that's going to also depend, because if this is a 30-year-old who has a parent that died at 36 or 40 with heart disease, or I still would get it just to make sure that there is not already propagation of calcium within those plaques within that vessel. So in terms of a hard number to say that at this point that they've got or what the cutoff is, my thing is if they've got family history, they've got an elevated LP little a, I'm sending them straight to coronary calcium scoring at that point. But in terms of therapies, which question, again, there's not a specific medication right now to address LP little a independently. It's coming, but it's not there yet. The question of whether or not to put them on a statin, I probably would, but this isn't. I'm not talking about. These aren't in guidelines right now.
Right.
But the reason why is that what we know beyond statins just lowering cholesterol or lowering LDL, we know that statins also stabilize plaques, and so and particularly with people who are at risk for coronary disease or have had an event, it is the unstable plaque or unstable clogging of the vessels that can cause people to have heart attacks. And so to the extent that you can stabilize those through statins, in my opinion, is a good thing.
Definitely.
But I think when we have this conversation next year, I can talk to you about medications. Right? Yeah, exactly.
And also, we'd encourage their family members to get tested also. Is that correct?
That's correct.
Right.
That's correct.
So I want to make sure that if someone comes up with the lipoprotein little a, that encourage family members to get tested for it too, because they're more than likely will have a higher cholesterol and increased risk of cardiovascular disease.
Correct.
Okay. So now somebody comes in, Doc. What are some of the symptoms? We talked about asymptomatic, right? So what are the symptoms of people having blockage of their arteries in their heart? What people need to look for?
Yeah. The most common symptom that people report is chest pain. Now, I'm going to talk about men and women. So, starting with men, chest pain is going to be number one. Typically, or they may report chest pressure, like chest pain, chest pressure. Hey, doc, something it felt like an elephant is sitting on my chest. I was having trouble breathing. They'll feel, and they may report associated nausea. They may report that they also have sweating at the time of that chest discomfort. Oftentimes, people report feeling more short of breath. So let's say they're in a neighborhood, they do a neighborhood walk on a regular basis. They're walking up a hill that they've walked up for the last 10 years, and all of a sudden they've noticed, hey, when I'm walking up this hill, I'm getting a little pressure. I'm getting more winded than usual. Something feels a little bit off. Fatigue is another reported symptom. Now, what I don't want people leaving here thinking that just because I'm fatigued, I'm having a heart attack, or just because I'm short of breath, I'm having a heart attack. But these are just, it's kind of, we may have the chest pressure associated with these other symptoms. So we kind of want our radar up in that situation. With women, it's a little more complicated from the standpoint, chest pain is still the number one reported symptom, but also a very close second is shortness of breath. And oftentimes you can have situations where women may not have chest discomfort, but they may have new onset shortness of breath. And I don't say this to panic people that every time you're short of breath that you're having a heart attack, but I just say that to emphasize the point that women tend to have a little more what we call atypical symptoms. They may also report new fatigue more commonly than men do in that situation. But if I were to say the big three in women, it's going to be chest discomfort, shortness of breath, fatigue. Those are kind of the big three as far as the symptoms are associated. Oftentimes, this chest discomfort may, but it may not. Also, it may move up your neck, and down your left shoulder. Those are other symptoms that can be associated with potentially a blockage or obstruction of blood flow in the heart muscle.
Okay. So now that we've determined someone comes to my office and they're giving me these symptoms, and so now I know I need to refer them to you. And at that point, what testing should they be aware that they'll possibly have to do to diagnose whether they have coronary artery disease or not?
Yeah. So when we're seeing patients that are clinically stable, I mean, we're not talking about someone who suddenly having a heart attack. We're talking about people who may just have symptoms. In this situation, when they see us, we'll talk about doing some type of stress testing. That stress testing may be just walking on a treadmill and monitoring you. When they're walking the treadmill, we're looking to see if we're seeing changes in the EKG in real time that might indicate there's an obstruction of flow. We may also set patients up to get exercise stress perfusion imaging, and what that is again we have you walk on a treadmill, but in this situation we give you a radiopharmaceutical that allows us to see blood flow to the heart muscle. It's a non-invasive way of assessing if there's any type of obstructive disease, and it's very good in terms of picking up any blockages. For patients that I'm hearing have a very good story, may have some EKG changes, and are at very high risk, we may go directly to invasive testing through cardiac catheterization. That's a minority of patients, but it's someone, if I hear a very strong history and like, hey, and I'm pretty sure that's what's happening, we may go straight to that. But we start off with the non-invasive being treadmill, being the stress perfusion study. Another option is to have you walk on a treadmill and do an echo. We call that a stress echocardiogram. In that situation, you're walking on a treadmill, then we immediately image your heart to see if there are any type of change in the way the heart muscle is squeezing that would indicate that there may be some type of obstruction of flow. This is also a non-invasive way of testing for heart disease.
Is there any role for like a CAT scan with dye, CT angio?
CT angio, I look at, the role for CT angio at this point is going to be in that patient who has who has significant risk factors, a pretty good story, and generally after stress testing. And I say that because CT angio is not benign, as cardiac catheterization is not benign from the standpoint when you administer contrast to a patient, they are going to be at risk for that's related to that contrast. That's in particular, patients can develop, it can have an impact on their kidneys. So it's not completely benign. I tend to like it like the CT, cardiac CT, coronary CT angiogram. In those patients that may have kind of a borderline stress test or ongoing symptoms, like sometimes the stress test can get it wrong. But it has ongoing symptoms. Let's say, hey, I need to take a look, and I'll send them for that. So it's kind of that. It's not the high risk patient. It's going to be that patient that's kind of low risk that may have, a borderline stress test or ongoing symptoms that where the stress test may have been normal, but I want to take a close look. I think cardiac CT is a great test in that, because you don't necessarily want to take them into a cath lab if they kind of have a soft story or a test that's not really very conclusive. That's a less invasive way of getting a very good answer in that regard.
And so once you find, you take them to the cath lab, look and see what's going on. They have blockages, and there's different treatment options for those, right?
Correct. So in that situation, one of the things that, particularly in the situation where somebody is coming in, what we call electively, so they're at home, they're having kind of chest pain that's coming. We do a stress test abnormal. We take them to the cath lab. We see there's a blockage. Now, this is where things have changed in the last 15 years, 12 years. We used to throw stents and say, that's it. But it is important to make sure that sometimes those blockages, particularly if the stress test isn't deemed high risk, it's abnormal, but not high risk, because it's a continuum. You have normal, you have low risk abnormal, moderate risk abnormal, high risk abnormal. Amongst those patients that may have low to moderate risk abnormalities, it is important to make sure that we give a trial of medical therapy, even if they may have a blockage. So there have been situations where I take someone to the cath lab, they have a blockage. We say, okay, what we need to do at this point is make sure we have you on appropriate medical therapy. That's going to be medications like nitroglycerin, beta blockers, which can slow the heart rate down. And if they're still having symptoms despite medical therapy, then we have an indication to go ahead and potentially put a stent in. And what a stent is we go across that blockage, we take a balloon and open it up, and then we put a stent in to keep the vessel open. Those stents stay there for the rest of your life, and we know that that they will stay, that their risk of closure in this day and age is about 7% over the lifetime. I really less than that. So they hold up very well, but it's not something that is just kind of arbitrary and capricious. We got to make sure we do appropriate medical therapy. And if that fails, then we put stents in. The circumstance where it's very different is if you've come in with a heart attack. In that situation, we're not waiting to see if that thing's going to get better with medication. We got to fix that thing, open it, put a stent in, and that's that. But in someone who's just coming in with kind of symptoms of recurrent chest discomfort that's stable, then we make sure that we do appropriate medical therapy. And if that fails, then we go to the stenting.
Okay. And then the only thing after that is, patients that may need surgery, right? Bypass.
Right. Yeah. Yes. And so that's, I try not to keep the surgeons busy, but we can't fix everything. And we have to recognize our limitations. And certainly someone who has what we call blockages in multiple vessels or multi-vessel coronary artery disease, those are the type of patients that we talk about potentially for surgery, or for patients that have left main disease, which is the main vessel coming off of your aorta that supplies blood to the heart. If there's a significant obstruction there, then we start talking about potentially bypass in that patient as well. And bypass is open heart surgery. That's where you crack open the chest. You have to, it's a major surgical operation. You're bypassing those vessels that are blocked. And generally patients do very well, but it's a significant procedure.
So I think we've talked all we can about coronary artery disease at this point, and we have
Mhm.
another topic too called a lot of people have heard of congestive heart failure.
Yeah.
Okay, and can you just tell us about that? What is
Yeah,
that?
so congestive heart failure is it's a situation where the heart is not meeting what we call the metabolic demands of the body, which basically means it's not mobilizing blood effectively to our organs. And so as a result, you can get in a situation where fluid starts to back up on the lungs and to the lower extremities because the heart is not working as efficiently as it needs to be to move that blood along to the rest of the body. So it's in the name. It's congestive. You get congested. The vessels are congested, and that pushes back on the lungs, and fluid builds up. And so we really got to try to get that fluid off them. Now, congestive heart failure. It's not a situation. It can be most commonly it's related to a problem with the way the heart muscle is squeezing, but it can also be related to the fact that the heart muscle doesn't relax appropriately, and so ultimately it starts to back up. So we have what's called heart failure with reduced ejection fraction, which means the heart is not squeezing well enough to move blood along. And then we have heart failure with preserved ejection fraction, where the heart muscle may be squeezing beautifully, but because it's not relaxing appropriately, pressure is building up and it can back up on the lungs as well. So congestive heart failure means the heart is not meeting the metabolic demands of the body, and as a consequence, the organs to your body aren't getting the right amount of blood they should in order to function as optimally as they should.
Right. And so, so people that have congestive heart failure, the symptoms that they start to experience when they have this, can you tell us about that?
Yeah, the patients will feel tired. They'll get short of breath. They'll say, "Hey, I'm walking over to the bathroom. I'm getting winded." And it's new. It's they recognize that things they have been able to do typically, suddenly they're not able to do. They're having more trouble getting up the steps. They're having trouble walking up that hill they used to walk up every day. They may also see that they're getting swelling in their legs. Okay, they start to get they're saying, "Wow, why are my legs swelling up?" They will report that when they may go to bed, it's more difficult for them to lie down flat in the bed because they feel like feeling congested, like they feel like they're having trouble breathing. Patients will also report that they're waking up in the middle of the night multiple times, having to urinate. Now, this can also often be confused with potentially with prostate issues. But if a patient is saying that they're getting more shorter breath, they're waking up frequently in the middle of the night because they're having to use the bathroom, that can all be signs of congestion or fluid being backed up. Patients will also report suddenly that they may wake up in the middle of the night feeling like they need to get to a window because they're having trouble breathing. So all of these symptoms are things that go along with someone potentially who has congestive heart failure. And certainly if you're having those symptoms, you want to check out, go and check with your primary care doctor
Right.
and see what's maybe going on.
Right. And even just getting up, not only going to the window, they can't make the door. They just usually just sit on the side of the bed and just kind of lean forward to try to get the air, So that's one of the other symptoms. But it's not just one thing, it's you putting everything together, right? To
Yeah.
try to
Yeah.
see what's going on. And so what causes it? What causes people to have congestive heart failure?
Yeah, the big three are going to be number one, long-standing uncontrolled hypertension. So we're going to circle back to hypertension we talked about a little bit earlier. You got to get that blood pressure under control because, again, it being the silent killer, it can kill your heart if you're not taking measures to get that blood pressure under control. The number two is going to be coronary artery disease or blockages. Blockages that have caused damage over time. They can lead to congestive heart failure. So here again, checking in with your primary care, getting an EKG. If you're having chest discomfort, let your doctors know, and they'll get you to see us to kind of get a sense of whether or not there might be blockages that are accounting for this. Other big one is going to be infections. Okay, viral infections or bacterial. They can certainly cause damage to the heart muscle. Obesity, as it relates to causing potentially sleep apnea, can also lead to heart failure. Alcohol use is notorious. I can't tell you how many times people come in who have used alcohol, have binge drinking or been drinking for a long time. That can also cause congestive heart failure. So those are kind of like the big four. And then the number 5 is going to be what we call idiopathic, or some people just develop it for reasons that we can't account for. So those are kind of the big 5 that we think about as far as relates to congestive heart failure.
So when you talked about like alcohol, viruses infecting, these are things that are affecting the actual muscle of the heart.
Correct.
It's not even the blood vessel, it's the muscle of the heart that makes the heart muscle weak, where you can't pump that blood out like you normally would. And so that's how you get the backup of the blood in the lungs and so forth. There's another one too, I think, which like amyloidosis or you have different diseases that can actually, affect that heart muscle.
Correct. Less common, but nonetheless prevalent. What we call those are infiltrative disorders to the heart muscle. So things like amyloid sarcoidosis, eosinophilia. There are a number of different infiltrative, and what that we mean by infiltrative, it means that it's entering the heart muscle. Okay, it's affecting the heart muscle. Particularly with amyloid, there's protein buildup in the heart muscle, and amyloid has been a very hot topic over the last 5 years, really 8 years, because what we're seeing is that it's often underdiagnosed, and so one of the things that the campaigns that's been going out there is to try to educate people on amyloid in terms of kind of the signs and symptoms. So the people that and I don't want anybody to panic who's on this to say, oh, I've got carpal tunnel, I may have amyloid, but it is something that we think about with those patients that may have carpal tunnel syndrome, those patients that may have neuropathy, some of our diabetic patients, and this is in tandem with some symptoms, generally speaking. But there are certainly risks for those patient population that may have heart failure symptoms, along with history of carpal tunnel syndrome, neuropathy, diabetic, and the like.
Mm-hmm. So when patients are having, some of the symptoms of shortness of breath, and walking, and sometimes you have certain lung diseases that may also, give you some of these same symptoms. Are there any testing that we can do to kind of differentiate, I guess?
Oh, absolutely. And the testing is going to start with your primary care with Dr. Ford. They'll first get an EKG, but the EKG may not show anything. You may then have you see a cardiologist, and then we do a study called an echocardiogram. What that is an ultrasound of the heart. Some people, if you've been with your wives or women who've had ultrasounds of the abdomen, we use that same probe and move it up to the heart, and we're looking to see how the heart muscle squeezing. We're looking to see how the heart muscle relaxing. We're looking at the heart valves, and we're trying to get a sense of whether or not there's anything structurally wrong with the heart to account for why you're having these symptoms. So if we see a situation where someone has significant problems with heart muscle squeezing, that tells us that it's likely heart failure. If we see a situation where the patient may have difficulty with the way the heart muscle relaxes, that tells us that there's likely heart failure going on. So the echocardiogram is an essential tool in our tool belt in trying to assess whether or not there might be when the patient may have heart failure. And as you said, that the other thing I forgot to mention was valvular heart disease is another cause for heart failure as well that I didn't mention earlier.
Mm-hmm, mm-hmm. And there are also, it's like you said, there's other screening tests that we need to do as far as even blood tests, right? Obviously, taking a good history is always important when you're assessing a patient. But there are other things. People can have, overactive thyroid glands, right? Hyperthyroidism. These are just rarer things, but these are things that are so treatable that you can help the patient out. Then sometimes too they have these get a BNP test, I guess, more for hospital to see whether that can give us a good idea whether this is truly congestive heart. Doesn't say what type you have, but just the fact that you're in heart failure. That's a blood test. Yeah.
Critical tool, particularly with our patients that may have COPD or asthma, because those can look very similar. So the proBNP can help us differentiate whether or not there might be heart failure. There's one tricky thing with the proBNP, though, is particularly with obese patients and particularly with obese women. It can falsely reduce the proBNP. So in that situation, there can be patients that may have all the clinical signs and symptoms of heart failure, but have a relatively normal proBNP. That's the group where we still have to be vigilant, because it can give us a false test, basically.
Mm-hmm. Okay. And so so now we've diagnosed the patient with heart failure. We know whether the pump is not pumping well. We know if the heart's too stiff. And then, the main treatments that we give patients because they're fluid overloaded. If you can talk about that.
Yeah. So the beautiful thing, there's been a lot of research in heart failure, and we are doing a better job. Untreated, you're still at a 50% risk of dying within the first 5 years if you're not treated for your heart failure. But we have made significant strides. So first off, we give medications that are designed to get fluid off of you, and that's where you hear people talk about Lasix or furosemide, where we're trying to actively get you out of that state of having too much fluid to getting to a place where you're back to a fluid balance, which is what we like. So that's what we do in the short term. Beyond that, there have been multiple medications that have been found to have a significant benefit in saving lives. Heart failure is a space where there's been so much research done that we do have a multitude of medications that are there to help us, starting with medications called ACE inhibitors and angiotensin receptor blockers, ACEs and ARBs. Clear benefit in terms of saving lives. There are medications. There are 3 medications called beta blockers, but these specific 3 that have been shown to have benefit in this space. One is metoprolol, succinate. The other in this is carvedilol, and then the third one is bisoprolol, which is mainly used in Europe. For our purposes, metoprolol and carvedilol are the main ones that we use in the U.S. Then there's the one that people have seen probably ads on and still see ads on, which was really a remarkable medication called Entresto. It's valsartan sacubitril. That is the generic formulation of the drug. That is really one of the best ones that we have out there. So much so that it has really replaced the ACE and ARBs as first-line therapy in heart failure. So Entresto is a fantastic medication. Another one is spironolactone, particularly with patients whose hearts, the function is less than 40%, 35%. That has been shown to have a very clear mortality benefit. Jardiance or empagliflozin, as well as Farxiga, which is dapagliflozin, both those medications have been shown to also have a benefit in terms of reducing death in heart failure. So there's just a multiple amount of medications, and to the extent that we can get you on all those medications, again, they've been shown to be useful. We have to understand that we don't practice cookbook medicine. We recognize that, while we'd like to get you patients on all those medications, sometimes because of blood pressure or intolerance, that we can't get all of them, but to the extent that we can get them all on board, we try to. Oh, and the other one I have to, particularly given who I'm talking to, other important medications is a medication called Bidil, which is isosorbide and hydralazine. And there was a study involving African Americans called the AHEF trial, African Americans with heart failure. They had a reduction in the way the heart muscle squeezed. Bidil had a clear benefit in terms of saving lives in that population. So there are a number of different medications that we have for patients that have heart failure with problems with the way the heart muscle squeezes.
So we know heart failure would reduce ejection fractions. We know heart failure that has preserved ejection fractions. So is Entresto or Bidil as effective in the preserved?
They are not. And what our guidelines have shown is that actually the medication there's no class 1 or the leader. The best thing that we have is actually going to be that dapagliflozin and Jardiance in that population. For those patients that have heart failure preserved ejection fraction, we want those patients on those medications because they have been shown to have a benefit, and they have the highest the most data behind them at this point in terms of utility. In that population, we still want to make sure we control blood pressure and what have you, but you got to have that dapagliflozin or empagliflozin on board in that situation. These are called SGLT2 inhibitors.
Right. It looks like we have a bunch of questions I'm being
Okay.
told in the comment section. I guess they can bring some of the questions forward, and maybe we can start to answer some questions of everyone. I think they're getting ready to load them up because I know we're close to our hour's time, but I don't know if maybe we have to go a little overtime on this one.
Sure.
Told me to check on the right side, but I don't see.
Yeah, there are. But
you see questions?
I just clicked on the comments. I was like, "Woo!"
Oh, okay. Yeah, I didn't see all this. Okay, so you see. Wow. Okay. Where we're going to start?
Can I take one question I'm looking at
right
here? And it's something I want to talk about. The question asked about vaping, cigarettes, and cigars, and I hope, and this is the perfect, I guess, platform to talk about this. There is, and I say this as a Black male who socializes with Black men. There is something that has happened in the last 10 years that has me very concerned, and it centers on the way that we socialize with cigars. Bunch of my boys, they will smoke cigars, and there's this thinking, or I believe there's this feeling that cigars are somehow better than cigarettes. What we have to understand is that with each cigar, there at a minimum is equivalent to 6 cigarettes in that single moment that you're smoking it. And with some of the bigger cigars, it can be up to as much as a pack. Okay, that's with a single cigar. So there, and what we're concerned about is the nicotine that's in that cigar, because it affects the way that blood circulates and affects the way that the vessels respond in terms of relaxing. It has a negative impact on both, and they also have toxins in them. Maybe not as bad as cigarettes, but very close. And we know that increases patients' risk for cancer, particularly if you do this with any regularity. So we got to be cognizant out there, brothers. We cannot think that these cigars are just a benign thing, and we got to change up how we socialize around them.
Well, I know that was directed to a lot of people.
Yeah, I mean, I got buddies of mine I'm going to see this evening, and I'm like, we gotta change it up.
Okay, so let's hit a couple questions here, Doc. Let's see. It says, which plays a larger role in heart health, family genetics, or the combination of diet and exercise?
That's tricky. Great question. It really is going to depend. There are, and I'll say this: there's a buddy of mine who is a cardiologist, ate right, exercised on a regular basis, ran marathons, and during one of his training sessions, he started getting more chest discomfort and shortness of breath. Came back stateside, underwent a cardiac catheterization, and found a blockage in the main vessel to his heart that if he closed off, he would have died. Now, he had 0 risk factors, but he had a situation where his father died of a heart attack at age 48. Okay. So it's hard to say what for every person is going to be a little bit different, but in that person that may be doing all the right things, that has a very strong family history of premature heart disease, that was bigger than him and then diet and exercise. So generally speaking, it's hard to generalize across to say which one is going to be higher than the other one. It's very much individualized.
Okay. So we have something else here. What are some common misconceptions about individuals who have healthy hearts? I'm not sure about that question.
Well, maybe that well, just because you're thin, okay, and doesn't necessarily mean that you're heart healthy. There are plenty of people who may not be obese, but at the same time, they may have a cholesterol through the roof if they're not being checked out. So your waistline does not necessarily mean that your heart is fine, but it certainly doesn't prove. It does take a risk factor off the table, but doesn't mean that you still need to be checked out by your primary care to make sure everything is okay.
Caffeine, does that affect the heart?
Uh, I swear there's a study every year about caffeine is good for the heart, then it's bad for the heart, then this year it's good for the heart. So what I can say is that in terms of heart rhythm, it does tend to increase your heart rate. It can, in some patients, lead to an irregular heart rhythm. Particularly our older patients, it can induce some or trigger atrial fibrillation. But at this time, there is no statement from the American College of Cardiology, American Heart Association, saying that caffeine has any type of negative impact on your heart. It kind of, and I swear there's a study that comes out every other year going back and forth on that issue.
So it says for those that have heart disease that's hereditary, what can we do to reduce this factor in us?
Well, you can't change your parents. I mean, that's the bottom line. Now, the question is the heart disease related to another condition like familial hypercholesterolemia? And that's a situation where a very high cholesterol level that is running in your family that people may not recognize. And to the extent that if there is an identifiable hereditary issue that can be modified, as example, familial hypercholesterolemia, then there could be a situation where we put you on therapy to reduce that cholesterol level. So,
Right.
so it's really finding out whether or not it's like familial hypercholesterolemia, LP little a, which is another big one. If that's a condition that's running in the family, then we might be able to modify it in that regard.
Right. And all of that is making sure you're getting checked out.
That's right. That's
Right.
good.
So
It
you're
all comes
going
back
in
to you. They need to come
to,
see you and make sure they get checked out.
right, to make
Absolutely.
sure, see where your cholesterol is and see what your risk factors are. So that's so important to make sure that you're following up.
Absolutely.
Question was, do you have to wait to exercise while you have COVID, even if your symptoms are no longer there or acute?
Uh, so you, in terms of waiting, yeah, I mean, once you've recovered, and I probably I'll defer a little bit to my primary care doctor, but from a cardiovascular point of view, if you're no longer short of breath, you're not having symptoms, you should be able to get back to doing what you were
Right. I
doing.
agree. I mean, it just depends on how you feel, right?
Yeah.
If you're still fatigued, if you're still, coughing a lot, you want to just wait until you're feeling better, right? And once you feel better, it's okay to go back. Just missing a week or something of exercise is not going to really change what's your cardiovascular outcome.
Absolutely.
Let's see. What other tests should a person have doing regular checkups? I guess that's my area. So basically, we just mentioned all the risk factors for cardiovascular disease, right? Going into your physician, getting your blood pressure checked, getting blood work to check your cholesterol. Diabetes is a big risk factor, making sure that you're getting your blood sugar checked. And one big thing, also know your family history. Okay. So you want to know if your family members, everybody has diabetes, everybody has prostate cancer, everybody's had heart attacks before the age of 45, so knowing what your risks are, right? So you want to know your family history. If you're smoker, there's certain screening tests that we do, right? You can get screened for lung cancer at a certain age if you smoke so much. So there's multiple different things, but it's some of it's individual, some of it's just basic routine, just getting all the things we talked about that are risk factors, getting those things checked out to help decrease your risk of having those diseases. Says, is the problem with high blood pressure about blockages in the arteries or weakening or both?
It's not necessarily about the blocks in the arteries or weakening. It's what it is that so it it affects the ability of the vessels to relax. Okay, and when that pressure and as a result, it can start to have consequences in terms of how blood flows through those vessels. So the problem is not it's not a it's a problem when it's extended over a period of time where it starts to affect those vessels. Okay, it's not a result of the vessels. It's more so that when those vessels have been under such stress over time, it can lead to a change in the way their ability to function when you're trying to get that pressure down. So they start to get very stiff, and ultimately, over time, it can also lead to obstruction in flow.
Okay. Guess we're a little bit over time. We're gonna maybe get two more real quick.
Can I answer this one
Sure.
question from Anthony
Sure.
Kelly? How much improvement in the lungs and heart have you seen in both organs once someone has actually given up smoking and drink completely? With smoking in particular, it's actually remarkable. Within the first 2 to 3 weeks, what we first see is that your heart rate starts to go down. By month one, they start to notice that their breathing starts to improve. So you start to see improvements pretty quick. Oh, their sense of smell also starts to get better within the first month as well. So it's over a pretty relatively short amount of time, you start to see these changes. Now, as a risk factor, it still exists. I mean, it goes down incrementally as you get further out from the time that you quit. But so that takes years before you can even start talking about removing it as a risk factor. But in terms of your general feeling, less stress, heart rate goes down, breathing improves, sense of smell goes back, sense of taste improves. These things occur pretty quickly.
Mhm. Okay. Let's see. So how do you what does it say here? How do you separate symptoms of, say, panic attack from chest pain?
Oh, that's a great question. It's not easy. Is the bottom line. But because the three that run together, I love this question, are panic attacks, GERD, or we call indigestion, gastroesophageal reflux disease, and heart disease. They can look very, very similar. The problem or the issue is that we can miss a panic attack and get away with it. We can miss GERD and get away with it. We can't miss heart disease and get away with it. So to the extent that they look very similar, you really want to check with your primary care doctor. If they feel you need to see me, then we'll do the testing that's necessary to make sure that underlying issue isn't blood flow, because missing coronary artery disease is unforgiving. So there is no like oftentimes when we're getting the history, it is very difficult to determine which one of those three they can be, and they do often require some just additional testing to make sure that's not the fatal kind related to coronary artery disease.
Are there any type of pain in the chest with congestive heart failure, or is it only the feeling of shortness of breath and being winded?
Generally speaking, it's now in the situation that the heart failure is a result of coronary artery disease, then yeah, they can run together. Okay. And so, but in situations where it's purely heart failure that is not related to blood flow problems of the heart muscle, then generally speaking, it's going to be the things that we are talked about earlier with regard to chest shortness of breath, fatigue, lower extremity swelling, waking up at night to use the bathroom, those type of symptoms. So it's not usually chest discomfort won't go along with it unless the heart failure is a result of blockages to the vessels.
Okay, I think we got two more. Do patients make a full recovery once they've been diagnosed with congestive heart failure, given they make significant lifestyle and diet changes?
Some do, yeah. One of the mistakes that we made early on with heart failure, with patients who may have heart failure where their squeeze is less than 35%, we used to put defibrillators in. We'd have patients come back, or what boxes in the heart that shock the heart for those people who have heart failure. I say that because what initially would do is have them come back in 3 months and then their heart was squeezing fine. We then realized that, oh, wait a minute, these patients do recover if you get them on optimal medical therapy. So yes, a significant amount of people do recover fully from this. And for the ones that don't, then we have to, obviously look at continue them on good medical therapy. But there is a significant population that will, particularly the ones that have heart failure related to hypertension, that if we control the blood pressure, a lot of them can get recovery through proper medication, through exercise or cardiac rehabilitation, and the like.
Last question. What are the chances of a patient coming off medicines like Carbidopa or Entresto once prescribed?
Well, it depends what it's prescribed for. If in the setting of heart failure, they're committed to that, because we know that if they come off it, there's an increased likelihood they will go back into heart failure. So if they're on Carvedilol and Entresto because they had heart failure with reduced ejection fraction or heart failure where the heart's not squeezing well as it should, they're going to be committed to that for life.
Right, because that muscle doesn't recover.
Correct.
Right, unless
the medication is helping in terms of that recovery. Correct.
Right. Well, I think, Doctor, we've answered a lot of questions, although we didn't get to a couple of things. I think maybe we might have to have you come back at some point.
I'm at your disposal.
Right. We appreciate you and all that you do for the community. And Gamma Pi Health Initiative Committee, thanks you for your service here today. So thanks, everyone.
Dr. Ford, can I say one quick thing quickly just before we sign off?
Yes, sir.
Folks out there, we are in an unprecedented time right now. And I say this because we lived through this a few years ago. But I would just ask that people, because I see a lot of patients that are coming with stressed and with chest discomfort, it is a real thing. Got to turn that TV off sometime and just make sure to take care of your mental health, because your mental can affect your physical. And I definitely have started to see people coming back in with chest pains because we've got somebody who wants to run off with the mouth and do hostile things to our people. So that's all.
I agree with that statement 100%, sir. As definitely I'm seeing more patients come in who, are stressed over what's going on, especially in our area in the DMV. Right here where federal government workers are, we have a lot right here. So, all right. Well, thank you again. We appreciate you coming on, sir. And everybody have a great weekend. Thank you.
Take care. Thank you.